Okay, well, let's hope
Okay.
they join us. In the meanwhile, we'll carry on. Okay, Dr. Lembethe, thank you very much. As the medical officer for obstetrics and gynae in Johannesburg, we really appreciate you doing this CPD meeting for the district and people beyond. So welcome, Dr. Lembethe. Please proceed.
Thank you, Prof. Morning, everyone. As Prof has just said, I'm Dr. Lembethe. I'm the medical officer in the district clinical specialist team on the obstetric diet. Today, we're going to discuss a very important topic, hypertension disorders in pregnancy, which, according to the Saving Mothers report, is actually a very, very serious problem and is actually #2 cause of maternal death in South Africa. Just an outline of our presentation. It will be the background, issues in the management, definition, risk and prevention, management, complications. Okay, on the background, like I said, looking at the Saving Mothers report of 2017, hypertensive disease in pregnancy, mainly preeclampsia and eclampsia, is the #1 direct cause of maternal death in Gauteng. The #1 cause of maternal death in general is actually non-pregnancy related infections, which is HIV related infections. But direct cause of maternal death is actually hypertension in this situation. And most deaths due to hypertension are actually due to cerebral hemorrhage. The BP goes up, patient gets a stroke, and then also pulmonary edema because of the pathophysiology of preeclampsia with endothelial damage that happens. We're still gonna discuss that further. And another very important point is 75% of the deaths that happen due to hypertension are actually avoidable. Looking at how patients are managed during antenatal care, most of the time when we review the files and we do audits of the files, we actually pick up that most people miss hypertension, and as a result, patient is not managed and they present late, now presenting with complications. This is just a graph which I took from Saving Mothers report. And as you can see, it talks to the distribution of potential preventable deaths from 2008 to 2017. And as you can see, hypertension has actually remained a very big problem. That's the orange bar there. So hypertension, we haven't won the battle with hypertension as obstetrics in the management of, and it's killing quite a lot of our patients. And again, as you can see there, they're looking at causes of maternal death over a period. We can actually see that hypertension has not changed. I mean, in terms of maternal mortality rate, hypertension has remained a big problem. It hasn't gone down. Whereas if you're looking at things like non-pregnancy related infection, you can see that over the years, there has been quite a significant decrease. Okay, and then the last graph that I'm going to show you is the one which is looking at the fact that most deaths due to hypertension are actually preventable deaths. And somehow we either mismanage the patient or we don't make the diagnosis at the right time. Okay, just looking at a patient who comes into antenatal clinic and they are here and they have high blood pressure. It is very important for us to do the right thing so that we get the correct blood pressure reading and then we can manage it further. So the use of a correct machine and the use of the correct cuff, like I said at the bottom there. If the patient is, we have an obese patient with a MOAC of more than 33 centimeters, then we will have to use the correct cuff, so a bigger size cuff, because if you use a smaller size cuff, the blood pressure will overread. And then again, the use of the correct machine, and our machines at the moment are a bit of a problem because most of them are not being serviced and they are not being calibrated. And then how do we measure the BP on a pregnant woman? We actually need to measure it with the patient sitting. Patient needs to have relaxed for some time, at least for 30 minutes, take the blood pressure, and then take it at the right level, at the level of the heart, with the arms both relaxed. If the patient cannot sit, she will have to lie on her left lateral side, but you cannot take the blood pressure with the patient facing up, supine. Okay, and then let's talk about the definitions of what is high blood pressure in pregnancy. That is the most important thing, because this is where people miss the blood pressure. Blood pressure in pregnancy, if it's more than 140 diastolic, systolic, and more than 190 diastolic, that's high blood pressure for a pregnant woman. And these numbers are independent. So if a patient, for instance, has got a BP of 135/95, that patient is having high blood pressure because of the 95. And again, if the patient is having a BP of 145/80, that patient is actually having high blood pressure because of the 145. And then we have what we call severe high blood pressure, where if the systolic blood pressure is 160 or more, and or the diastolic pressure is 110 or more. Preeclampsia is when you have high blood pressure with proteinuria, and other organs may also be involved. We'll see later what other organs can be involved. But preeclampsia does not necessarily have to present with proteinuria. Sometimes you may have high blood pressure with just liver involvement, not necessarily with proteinuria. And then we also have imminent eclampsia, where you've got preeclampsia and the patient present with symptoms, and those symptoms could be headache, blurred vision, epigastric pain. And then the last form of preeclampsia is when the patient has got high blood pressure with either proteinuria or other organ involvement, and then also having seizures. Then there's one concept that we're talking about now, which is a borderline blood pressure for a pregnant woman. If the systolic blood pressure is 135/139 or 85/89 diastolic BP, that patient we need to watch very carefully, because these are the patients who present like this. We let them come 4-6 weeks down the line, and by that time they have severe preeclampsia or they have complicated. So these patients, we need to be very careful. We call them borderline BPs, and they need to be monitored very, very closely. Okay, and then classification of hypertension disease. The chronic hypertension, these are patients who have high blood pressure before pregnancy or before 20 weeks of gestation, and they are on treatment and they are known. Any patient with blood pressure high before 20 weeks is called a chronic hypertension. And then gestational hypertension is a patient who develops hypertension after 20 weeks of pregnancy, of gestation, and usually they just have high blood pressure. They don't have either proteinuria or any other organ involvement. And then preeclampsia like I said initially, is when a patient has got elevated blood pressure of more than 140/90 with proteinuria and sometimes with organ involvement. And it's possible that the patient may have organ involvement without necessarily having proteinuria. We'll see which organs actually get involved with preeclampsia. And preeclampsia can be mild or severe. If preeclampsia is severe, there are three forms of severe preeclampsia. It's either the blood pressure of more than 160/110, or the patient is having eclampsia, where the patient is having seizures. And then there's imminent eclampsia, where the patient is having preeclampsia with symptoms, which I mentioned earlier. And then also we have what we call HELP syndrome. HELP syndrome is actually when the patient is having, I'm going to just go up, when the patient is having hemolysis, and then elevated liver enzymes and low platelets. And then the last form of hypertension is when a patient is a chronic hypertensive, but after 20 weeks of gestation, she then develops preeclampsia in a form that she either gets proteinuria or she starts showing other signs of other organ involvement. Okay, and then again, looking at a patient at an antenatal clinic or when the patient is coming to book, we need to identify patients that are actually at risk of developing preeclampsia. And those patients are usually patients who have a history of preeclampsia in previous pregnancies, patients with chronic hypertension, patients with multiple gestation, twins, triplets, patients who have gestational diabetes, and again, also patients who've got high blood pressure, chronic hypertension, and diabetes as comorbids. And then maternal BMI of more than 33. So obese patients are also at risk of developing preeclampsia. And then patients who have a history of having had antiphospholipid syndrome or SLE. And then what do we do during pregnancy, during antenatal care to prevent preeclampsia? All patients who are pregnant are supposed to be started on calcium. Use of 500 to 1,500 milligrams of elemental calcium, starting as early as possible in the pregnancy. And then the patients that are mentioned above, those patients are high-risk patients, and those patients also need to be started on aspirin, which usually we start from 12 weeks of gestation, and they continue taking the aspirin until delivery as a preventative measure. Okay, and then, like I said, our biggest problem at the moment is preeclampsia. Patients with gestational hypertension, chronic hypertension, they don't really do that badly during pregnancy. But our biggest problem is actually preeclampsia, where we find that patients' outcomes are usually not very good. Looking at the slide there, we are going to see that there are organ involvement that I was talking about. It's either the kidneys, the liver, hematological impairment. You find that the patient goes into a DIC, platelets go down, liver enzymes go up, they get renal dysfunction where the creatinine goes up, and then neurological impairment. They can also get a stroke, a cerebral edema, and then also it affects the pregnancy itself, where you find that the patient either has growth restriction of the fetus, or they develop abruptio, or you get intrauterine fetal death. Like I said, the range of organ affected is due to endothelial dysfunction. We know every organ in the body has got an endothelium, and basically preeclampsia is a disease that affects almost every organ in the body. And it affects about 1 to 3% of all pregnancies. And the actual cause of preeclampsia at the moment is not clear. But in terms of pathophysiology, preeclampsia is a two-phase disease where you actually, at the beginning of pregnancy, you get what we call the placental phase, where the development, as the placenta is forming, the development of the uterine placental spiral arteries is poor, and as a result, you get increased resistance, and as a result, decreased blood flow. And then the second phase is the endothelial phase, where that placenta, which is starting to have problems, now starts producing a whole lot of multiple angiogenic factors, which are released into the bloodstream, and they go to the endothelium and they cause endothelial damage. And the main endothelial damage that happens is that the endothelium becomes permeable. Sometimes you find that platelets tend to attach to the damaged endothelium, and as a result, you've got decreased circulating placenta in the blood system. So the management of hypertension disease orders in pregnancy is, we'll take it according to the or to the severity rather. So when the patient is having hypertension, so that is the BP of 135 to 139 systolic and 85 to 89 diastolic. That patient, when you have such a patient at antenatal, you need to repeat the blood pressure after about 30 minutes to 2 hours. Let the patient rest. Make sure you've used the right machine, you've taken the blood pressure correctly. If the patient's blood pressure remains at that level, then you don't start them on treatment as such, but you make sure that you bring back this patient in 3 to 7 days to make sure that the blood pressure hasn't actually gone up to a frank hypertension. If the blood pressure becomes less than 135, 85, then the patient can actually be managed at the clinic as a low-risk patient. And then a patient who's got what we call gestational hypertension, so that is hypertension with no risk factors, no symptoms, and no proteinuria. Ideally, the patient must be started on Aldomet 500 milligrams or alpha-methyl dopa 500 milligrams 8 hourly. And then within 3 days, the patient must actually be sent to the hospital where further investigations can be done. Remember, at the clinic, all you've managed to find is just a high blood pressure. But the clinic is not able to assess if the patient has got other organ involvement. So this patient cannot be managed at the clinic. You start the management, you send them to the hospital. At the hospital, they should actually then do more investigations to exclude preeclampsia. So they would do things like blood tests, and then they would also do an ultrasound to look at the fetal growth, do Dopplers, and yeah. So this patient, yes, can be started treatment at the clinic, but immediately sent to the hospital, not necessarily on the same day. And then a patient who's got hypertension with proteinuria and symptoms suggestive of organ involvement is actually a patient with preeclampsia. Like I said, preeclampsia, all patients with preeclampsia are managed at the hospital. And ideally, they are supposed to be managed at either level 2 or level 3 hospitals. So these patients need same-day referral to the hospital. At the hospital, these are the investigations they will do: blood pressure, HB, platelets, urea, creatinine, ALT, LDH. LDH is actually a marker to look at whether hemolysis is starting to happen. And then they will do fetal evaluation, like doing Dopplers, looking at fetal growth, and then looking at glycovolume as well. Okay. And if the patient is now having severe preeclampsia, what is severe preeclampsia? These are the patients who either have eclampsia, which is fitting with high blood pressure. They have a blood pressure of more than 160, 110, or they are having preeclampsia with signs of imminent eclampsia. Those patients are supposed to be seen at the clinic, managed immediately at the clinic to stabilize them. So what does the management involve? It involves putting up an IV line of 200 mL normal saline or ringers. To that, you add 4 grams of magnesium sulfate, and then you run it over 20 minutes. And then with that, you give 5 grams of lignocaine. Sorry, I didn't write lignocaine there. Lignocaine on each buttock. You give 5 grams of magnesium sulfate with 1 ml of lignocaine, because magnesium sulfate IMI is very painful. So you give 5 grams of magnesium sulfate on each buttock. So it's going to be 5 one buttock, 5 the other buttock. So the total loading dose for preeclampsia magnesium sulfate is 14 grams. And then after giving magnesium sulfate loading dose, you need to keep on checking the blood pressure every 15 minutes. And the blood pressure that remains above 160, 110, you need to reduce the blood pressure, because that patient has got a high risk of developing a stroke. So, and to reduce the blood pressure, we need something that will act very fast. So we use nifedipine, 10 milligrams. You give it orally. Patient drinks the tablet whole. If the patient is unconscious, maybe she was fitting, now she's semi-conscious, you can actually take the same 10 milligram whole tablet or capsule, put it under her tongue. And the other drug that you can actually use is labetalol, which is unfortunately not readily available in our PAC facilities, but it's an IV drug that is also used to decrease blood pressure urgently. Okay, and then as part of management of preeclampsia, it is important for us to take care of the fluids that we give to the patient. We need to minimize fluid intake, because remember, the endothelium are damaged, they are permeable. If you start giving this patient too much fluid, the fluid will escape into the interstitial spaces. So, and the most common complication of that will be pulmonary edema. So they say preeclampsia patients, you'd rather run them dry than overload them. So you have to give as little fluid as possible. And usually what we do, after you've given the Maxalf, that's 200 mils with 4 grams, you then put up 200 mils of normal saline again, and you regulate it to run at 80 mils per hour. Now, sometimes you find that the patient is not, is having oliguria, If the patient is only having oliguria, they say you can only bolus that patient once with 200 ml. Remember, you don't want to keep on giving more and more and more fluid. So you bolus them once with 200 ml. If the urine output is still less than 25 ml per hour, don't keep on giving more. Just stop and go back to giving the patient 80 ml per hour, because you don't want to overload them. Okay, and then as a start of the management, you can also give 1 gram of methyl dopa. This is not an antihypertensive that will work immediately. It will actually start working after about 24 hours, but you are already starting the process of managing this preeclampsia. So you can give it orally, and then together with the nifedipine. You insert a urinary catheter because you need to monitor urine output every hour. And then, as you can see, worrying about the fetus is actually the last thing. You need to stabilize the mother first. Once the mom is stable, then you can start worrying about what is the situation with the fetus. Is the baby alive? If you need to monitor, are you going to monitor? But again, monitoring a fetus in a preeclamptic woman when you are not at the right level of care, you don't have blood results, sometimes it's not necessary, because you monitor, you find fetal distress, then what do? It becomes a problem. So stabilize the mother, just check and note on the notes the condition of the fetus. While the patient is awaiting transfer to the higher level of care, monitor blood pressure, pulse, and respiratory rate every 15 minutes. And a patient at PAC level, you would expect that this patient will have left the primary health care to a higher level when before the ambulance, usually the ambulance must come before 4 hours. But if the ambulance delays and it doesn't come and 4 hours passes since you gave the loading dose, you may have to give the patient maintenance doses, which is 5 gram magnesium sulfate IMI. So if the patient stays with you for longer, every 4 hours you give them 5 gram of magnesium sulfate IMI. And then the patient will go to the hospital. At the hospital, they will make the right decision. But if they need to continue monitoring the patient, they will do it having given the patient maintenance dose. And then let's talk about the patient who's actually fitting. If a patient comes in and is fitting, you need to call for help. You need to prevent the patient from injuring herself. So basically, you put this patient on a cot bed, and you will nurse the patient on the left lateral side. Typical eclampsia, the patient fits, and then they stop for a while. If no treatment is given, nothing is, then they will fit and they will stop for a while. And in between, usually the patient gains consciousness and the patient is okay. Ne? So, okay. Hello. Melissa, are you having a question? Sorry about this.
No, carry on, Zanele. Finish and then.
Can we finish? Okay.
Yes, finish and then we'll take questions.
Okay, thanks, Bob. Okay, so a patient who's fitting, like I said, you have to nurse them on the left lateral side, maintain the airway. Sometimes you will have to give them oxygen, and if, after fitting, sometimes the patient has got a swollen tongue and they are struggling to maintain the airway, you may have to either put an oropharyngeal airway. If they are breathing on their own, they are maintaining the sense, you can just give them oxygen by mask. Check the BP, check the pulse, check the urine dipstick. And then give the loading dose of magnesium sulfate, which is 14 grams. And then look at the blood pressure. Remember, some patients, especially the young gravidas, they may actually develop eclampsia even with very low blood pressures. I've seen patients with a BP of 135/90, especially the gravida less than 17 years old, and they come in fitting. If the patient's blood pressure is more than 160 systolic or more than 110 diastolic, this patient must actually be given nifedipine to lower the blood pressure. And how low do you want a blood pressure to go? Actually, the blood pressure must not be too low. You don't want the blood pressure to crash down to 120/60. You actually want to keep their blood pressure just above 140/90. Because if you lower the blood pressure too much, then you start compromising the fetus as well. So, and then you need to transfer eclamptic oil. Usually they all go to tertiary level. And then once you stabilize the patient in terms of fitting, then you would check at what is the situation with the fetus. I mean, patient can have abruptio at the same time with all other complications. So you need to at least be aware what is going on. And if the pregnancy is less than 34 weeks with the baby alive, it's a good idea to give steroids just to help with the maturity of the fetal lungs. And then eclampsia, sometimes you find that you've given the loading dose of Maxaf, but the patient doesn't stop fitting. You can actually give an extra 2 grams of magnesium sulfate IV as a bolus and see what happens. But some patients, again, they still continue in spite of having received 14 grams of loading dose and the extra 2 grams. So those patients are what we now sort of call maybe status epilepticus. You would worry about those patients, and you would want to give them something more, something like Valium or lorazepam, just to help stop the fits. And it is quite concerning when a patient has got eclampsia. Like I said initially, eclampsia, they fit and they stop. Usually they recover, but if no treatment is given, they fit again. But when the patient now starts fitting continuously, then you would start worrying that that patient has actually complicated. And usually the most common complication is that patient is usually having a stroke at that time. And then where you are continuously giving more and more magnesium sulfate, you need to look out for signs of magnesium toxicity. A patient with imminent eclampsia or eclampsia, this is something I should have mentioned higher up. As one of the signs, they also present with hyperreflexia, increased knee-jerk reflex. But now when a patient is now starting to show signs of magnesium toxicity, you find that the knee-jerk disappears, and then the patient starts breathing slower, the respiratory rate goes down below 16 breaths per minute. And usually that happens because of the urine output that is less than 25. Remember, magnesium sulfate is excreted through the kidneys. So if the patient is not passing urine and you keep on giving more and more magnesium sulfate, the patient then may develop magnesium toxicity. And if you think this is what is happening, then you will need to stop the magnesium sulfate and give a magnesium sulfate antidote, which is calcium gluconate. You give it as 1 gram IV. Okay, so, and then this is now a patient being managed at the clinic and then transferred to the hospital. So I haven't really covered the management of at the hospital level. I was just trying to address how we manage preeclampsia at our primary healthcare level. And then another important thing, at the hospital, patient will be managed. They will make a decision regarding delivery, but in most cases, if the patient is having severe preeclampsia, the delivery is usually the most important thing, because, as you know, delivery is actually the cure for preeclampsia. So patients with severe preeclampsia, they tend to be delivered earlier. Preeclampsia, you have to monitor blood pressure regularly in the ward. This is now after the delivery of the patient. Patient who had preeclampsia, usually we tend to keep them longer in the wards, in the hospital. Don't discharge them too fast. And if you do, make sure that either the blood pressure has gone right back to normal. If the blood pressure hasn't gone back to normal, you need to continue with the treatment and review the patient almost every week at a primary healthcare level, so that we don't have a complication of patients starting to develop complications because the blood pressure is not being managed. So patients with high blood pressure, on discharge post-delivery, monitor the blood pressure. If it has come down nicely, you don't have to give them treatment. But if the blood pressure is still high, you have to discharge them on treatment, and the patient to be reviewed at the local clinic 1 to 2 weekly. Patient who had eclampsia now, these patients actually, they need even closer monitoring. In the hospital, they are supposed to stay for 2 to 3 days post-delivery. And also after delivery, the patient, because they got magnesium sulfate, if they were eclamptic, usually they continue with the maintenance of magnesium sulfate until 24 hours after the patient was delivered. And again, eclamptic patient may fit after delivery. So if patient fitted after delivery, you continue the maintenance magnesium sulfate for 24 hours after the last fit. And then again, a patient with high blood pressure, fitting within 7 days postpartum, that patient is most likely an eclamptic patient, and management is exactly the same as mentioned above. Okay, and then complications of hypertensive disease in pregnancy, I already mentioned most of them. They are either maternal or fetal. A maternal patient may develop eclampsia, which is fit. They may develop cerebrovascular accidents and cerebral edema. They may develop pulmonary edema, renal dysfunction. DIC is very common with preeclampsia, liver failure, liver rupture. The epigastric pain that patients complain with imminent eclampsia is usually because there is swelling of the liver capsule that happens, and then the abnormal liver enzymes that you see on the blood results. And then abruptio placenta can also happen. Fetal IUGR and fetal death can happen. And then just to conclude my presentation, remember that preeclampsia is a progressive disease and the only cure for it is delivery. And again, there is no place for managing a preeclampsia in a primary healthcare setup. All preeclampsia patients must be managed at either level 2 or level 3. And management should be at regional, okay, I've already said that. And then patients, facilities where the patient presents, which is usually the primary healthcare facility, they need to stabilize the patient first before they transfer. So the severe preeclampsias, you need to give the Maxaf to prevent fits. Remember, magnesium prevents fits. it stops fits as well. And again, magnesium sulfate is the drug of choice for treatment of eclampsia and prevention of seizures in a preeclamptic woman. Thank you.
Thank you very much, Dr. Lembethe. I appreciate you spending this time and going through very important elements of care in hypertension for pregnancy. I think that you've pointed out what is really important is where we need to manage the hypertensive, especially if they complicate in the primary care setting, and how we might manage that in the few hours that we have before transferring that patient across to high levels of care. My question would be is, in essence, we'd be making that decision based sometimes just on the clinical presentation without having access to investigations. So perhaps when you see the hypertensive in pregnancy and begin managing them, and in the antenatal care space, is probably times when we do come across these patients and need to think carefully about our management of the patient. One comment, one question that came along was, where's the role of using magnesium as an oral supplement in that hypertensive in antenatal care? Any thoughts about the use of magnesium as a supplement?
Actually, I don't think that has ever been looked into. Maybe it has, but I'm not aware of it having been looked into, because mainly we're using calcium, but magnesium as a supplement at the moment, I'm not aware of. Maybe someone, maybe my consultant, if she's there watching, she could answer. But at the moment, I'm not aware of the use of magnesium as a preventative measure. We are actually using calcium and then aspirin for those with the severe history of severe preeclampsia.
All right, thanks. No, I just found something quickly. I actually just quickly searched for it now. There's a study, in fact, just published in April 2020 that suggests that, in fact, oral magnesium supplementation does not reduce the preeclampsia incidence in low-income and low-risk patients. So I'll just post it for those who are interested as something to read. I think those who have asked the question can have a look at that. I think the question, perhaps more importantly for me, would be the question of what sort of frequency are we looking at in managing the patient and repeating those bloods in pregnancy-induced hypertension in the antenatal care? We're talking about the LFT, FBC, UNE. What sort of frequency within your antenatal care visits, as you're managing the treatment, would you consider useful? Because that's really a key problem. If you pick up any organ damage, that is going to say, listen, this patient here needs to get urgently higher, even though they have not got any more, have not fitted. There's nothing to suggest except the hypertension. So you really need that blood test done regularly. How frequently would you do it?
Okay. Firstly, Prof, the blood test, we would actually not to do them at the clinic, because we would see them and then transfer them out. But if you have blood that are deranged, that actually is now an indication that this patient, you need to start thinking about delivering. So yes, maybe the platelets would start going down from maybe, let's say, 250 to 120. Yeah. That's a trend that you're looking at.
Yeah, no, I understand. But I mean, at the moment, most of the people on the call are not in the hospital environment. And I'm trying to figure out, just to clarify, maybe I missed it and maybe you're right. So in this primary care setting, if we find any pregnancy with hypertension, anyone with the blood pressure above 160 to 110, we would be saying refer. Now, referring the clinic, you've suggested referring from the clinic to a higher level of care. These come to the community health center. They may not necessarily, and that's the question I have, are the sisters in the clinic sending any such patients to the CHC, where they are now expected to look at managing that patient? Remember that they have not, there are no other signs. Would you say anybody with a blood pressure 160, 110, pregnancy would be sent straight away to hospital, irrespective. You've talked about checking it, but you're saying don't even bother to do the blood test. Send them along to the hospital.
Yeah, that's basically what we are saying, Prof. Because,
Okay.
you know, people will delay and do all sorts of things that the patient is complicating. So any high blood pressure, 140, 110, with us, the only thing you can do as primary healthcare, we say give aldomet, which is methyl dopa, 500 milligrams 3 times daily, and then make sure the patient within 3 days, if they are not severe, they must be seen at the hospital. And the hospital will do all the investigations and the sonars and everything.
No, that's useful. I think that's a question that, a related question that Dr. Mbuka or Degracious asked on the question, is that what if the patient's having a normal blood pressure and then hikes, you know, would you then refer, in other words, on one-off blood pressure? And I'm not trying to understand his question. He says the patient's pregnancy, blood pressure is normal, and then suddenly they have one high blood pressure. You said you'd repeat the blood pressure after 2 hours and 3 days later. Is that right?
Yes.
And then if that is still the case, you'd then say 3 days later, refer again.
Yes.
If the
because initially we were saying, Prof, maybe the patients with mild blood pressure with no proteinuria or any signs of organ involvement can be managed by the doctors at the CAC level. And remember, initially, preeclampsia was said to be just high blood pressure with proteinuria. If you have no proteinuria, you classify that patient as a gestational hypertension, which is sort of a mild form of hypertension in pregnancy. But now, because the definition of preeclampsia changed to say you can actually have preeclampsia without having proteinuria, but having other organ involvement, it will be very difficult for the clinics to tell if the patient is having any other organ involvement. So the best is for the patient to go straight to the hospital, exclude all possible organ involvement. If they are happy that this is a pure gestational hypertension, they may send the patient back. Other districts are doing that. That's their protocol. Our protocol in the Joburg district is that every patient with high blood pressure must be managed at the hospital level.
Okay. All right. Well, I think that it depends on the quality of the care, because I can imagine the family physician or yourself in a CHC being able to do those blood tests and perhaps the sonar and making that decision that this patient is actually quite fine. So I think it depends on the competency levels at the CHC. But you have chosen in Johannesburg to say all such patients should be referred straight to the hospital. No problem. We'll leave it at that. I think we're close on the hour. I think we've answered all our questions. I don't know whether there is anything else. So I think that postnatal, yeah, I think the question from Dr. Nkera is postnatal when persistently elevated on follow-ups in PHC. I think he might be saying, would that be sent to the primary healthcare setting? But you've said that they'll be kept in hospital until they are settled and you feel confident 3 to 6 days, like you said, depending on whether they're preeclamptic or eclamptic. So I think it's just about the postnatal care. I think one wouldn't want to send them to the hospital, to the clinic, if you haven't managed the blood pressure adequately.
Yes, I mean, the role of the clinic there would be when the blood pressure is sort of between 140 and 150, not severe, that patient can actually be sent to the clinic to continue management with the medication and being reviewed every week by the clinic and continue treatment. But now sometimes you find that other patients, they keep on having this blood pressure continuously up to 6 weeks post-delivery, the blood pressure remains high. So if the blood pressure is still high 6 weeks post-delivery, those patients should actually now be managed as chronic hypertensive.
That's right. So you really have to just manage that blood pressure. You're not going to send a patient who's not controlled down to primary care. I think Michelle asked, puts a statement out that patients that have abnormal BPs and blood tests are referred for admission, not managed in PHC. I think the point, Michelle, is that just a blood pressure is enough. You don't need to do the blood test, according to Dr. Lembethe. She's saying that not even the blood test should be done. They should be sent straight off for a referral to the higher levels of care. That's the protocol in our setting. My question was, could we not, having the blood pressure, do the blood test before we send them off? Because in a way, if you see a patient who comes in with an elevated blood pressure, I repeat it in 2 hours, I can then say, let me do these blood tests and tell the patient to come back in 3 days' time and look at the results. And I think that would depend very much, I think, on our context. But the overall advice from Dr. Lembethe is, don't mess around, send them to the hospital. Am I right, Dr. Lembethe?
Yes, because we've messed around with quite a few and the outcomes were not good. So, like I know Baragwanas, they are very strict. If you have a hypertensive, they want to manage it themselves. So just start Aldomet, send the patient to them. If there's any reason that they think the patient can be managed at a PhD level, they will make a note and say, manage this patient, bring them back if this and this and this happens. But they need to have seen that patient, because if anything happens and you never refer the patient, basically you have no leg to stand on.
Okay. Well, I think that is a function not so much of the protocol being best practice, but in fact the quality of care that seems to be available in primary health care. That says, listen, it seems like people are unable to do it, because what you're referring to the patient to the hospital for, as you've described, is simply doing the blood tests and doing a sonar. And if you're sitting in a place where the patient is literally 6 hours away from any other levels of care, or you are having difficulty, you need to understand what you can do and can't do. And it depends on your skill levels that you should be able to make that judgment. But err on the side of caution, refer the patient if you feel that you cannot, especially with maternal deaths. That's a huge stain on our health system. So please be very cautious. Anyway, thank you, Dr. Lembethe. We'll close now. It's 3 minutes past 9. I wish everybody, thank you very much. We appreciate you spending the time and answering the questions. I think it's doctors not just from the public service, but all over Johannesburg and in fact across Africa that have listened to you, Dr. Lembethe. So I'm sure they all appreciate it. So thank you very much. All right. Well, thank you all for attending. There are 45 people have listened. Bye-bye, everyone. Be safe. Go well.
Thank you.